I'll start off. Thank you so much, Tina, for the introduction. Really great pleasure to be here. Our panel, really excited to share the work that we've been doing and experiences that we've had. And as you said, Tina, it's not just about us presenting what we've learned, but also learning from others. So really look forward to the conversation and encourage everyone, please, to jump in and not to be shy when it comes to that stage. So I'm Amrish Joshi. I'm a palliative physician here in Richmond. And as I said, this was really a labor of love for all of us, and hopefully you'll enjoy the work. So maybe I'll tap my next colleague to introduce themselves.
My name is Sakina. I'm one of the palliative care physicians. I actually work in Surrey and Delta with Fraser Health, and Amrish roped me into this project. I think we were just discussing that it's been since 2019 that we've been working on this.
Good afternoon, everyone. I'm Monica Kelly. I am a social worker by background, and I am the lead for the Goals of Care support team, which is a regional team, but I specifically work in the community of Richmond and have the pleasure of sharing this research that was done by the other panelists and engaging with the clinicians and patients about how this can help the conversation move forward.
And my name is Laura. When I was doing the research with Amrish and Sakina and working with Monica, I was the educator, nursing by background with the Richmond palliative team, just currently in a different role, but my passion will always lie with palliative care. So we really look forward to having all of you join us today. And this was probably in the website when you guys signed up. So as Tina shared, we'll kind of summarize the key themes from our article that we really found as we were reviewing the transcripts from the interviews. And then from there, we're sharing kind of two main tables from our paper. One kind of summarizes the key themes, so we'll briefly talk on that. But the majority of today is we're really hoping to share those phrasing and adaptations that we identified during our interviews, and that's really where Monica comes in, since she's been such a big champion in sharing our findings with the rest of the teams in Richmond. And lastly, as Tina shared, we will have some case studies where we're hoping that we can pull those themes and the phrasing in to two specific case studies that a lot of us have kind of seen in practice, and hopefully it'll also kind of remind you of some of the cases that you've seen in your own practice, and we can kind of have a group discussion about that. So really just first a recap of the Serious Illness Conversation Guide. We really just wanted to reshare this resource from Ariadne Labs in case someone is unfamiliar with it, but this is the guide that we did use during our research in terms of introducing the structure, the patient tested language that they've identified, as well as kind of sharing I guess, possibilities for how we can make it a bit more culturally informed when we're having these conversations. Our study was focused on the South Asian population, but some of our learnings can obviously be applied to other groups and individuals. Amrish and Sakina, anything you'd like to add for the guide, or Monica as well?
So when we did this presentation before, I commented on the fact that when Amrish and I in particular were presented with the Serious Illness Conversation Guide, quite a few years ago, it was kind of put out to us as the best thing after sliced bread. And I think for me, I looked at it and I was like, these questions are a little bit strange. I don't know how well they resonate with me. And we were kind of told, you know what, you just have to get used to saying them. And, I don't know. It never fully resonated with me. So one of the things that came out of our work was that I wasn't the only one who felt that way. So I don't know if Amrish, I mean, you had talked about some other things in the past.
Yeah, so I think, again, and in a way, so Kenny, you're saying it didn't resonate. We all have our own culture. Culture just means sort of the behaviors or rituals we do, but you're specifically yourself and myself, we're talking from a South Asian background. And again, as we talk through this presentation, particularly communities, maybe particularly Eastern cultures where there's more of that family centricity. And I don't mean we don't have families that care about us, but families making decisions as one autonomous sort of structure, it sort of lands in a bit of an odd way, and that's what we mean. And so maybe I don't want to give too much away now, but I just want to echo what you said. So, okay, now hopefully are already getting an idea of what we're talking about and see it as we move through. And Monica, Lara, I don't know if you want to add anything to that.
I think for me, just recognizing primarily working in Richmond, although I do connect to across ACH, there is that truth that not every client that we are going to see was necessarily the population that this original guide was created and tested upon. And so recognizing those unique differences and perceptions that people feel, it's so appropriate that we revisit the questions and check in with people that are being asked to bring forward these questions for patients, and check in with patients about how does this feel with you? How does this sit with you? And that is the rest of this presentation, really, is touching base on that.
Maybe I'll just do a little logistical thing to point out before Amrish goes into the details of our study. But the version that is currently on your screen is actually the most updated one from Ariadne Labs. The one that we did for our study, since we did it back in 2019, is actually an older version that Vancouver Coastal Health was using at that time. So there are some wordings in this current version that you're seeing that have already incorporated some of the themes that we've identified, kind of just with Ariadne Labs, consistently trying to aim for the best possible language in providing this care.
So why this study? And so we've already touched on it a little bit just now, and Sakina brought it up. So, obviously, the Serious Illness Conversation Guide had been introduced. The idea about sort of exploring an individual's values and goals and how that's important in healthcare, right? If we really want to be providing excellent healthcare, we really need to understand where an individual's coming from, or their family, in terms of what are their values, what are their goals, what they want and what they don't want. And again, just to remind us, we're here in BC. South Asians are the largest visible minority in BC, so that's 28% as per census in 2021. And so it is important, and clearly have a major impact on the clients we're seeing as part of the care that we provide. And also just to, again, remind us that, we're getting older. Palliative care is becoming more and more important in terms of the services it provides with the population. And so that would also mean that, even more important, that if you're using a particular guide, that it has that cultural nuance to it. And so something that was really important for us to look at. So it brings us really to what we decided to do. So clearly we had this tool, and already there was an inkling from some of us, and even from discussions. And when I say inkling, from my perspective, I'll let Sakina jump in, but I looked at this tool and said, what happened if I use this with a family member? And I'm from a South Asian background, and I could already see some challenges. So, and we'll see those being flagged up as we did the study. But really, what we needed to do, a qualitative study, because we wanted to learn about experiences. It wasn't about quantifying. And so we had this idea. We need to get a group, focus groups of those who are from South Asian background. But we deliberately chose those that could speak English and communicate in English, and that would be one of our faults and weaknesses of the study. But it made it easier for us, at least, to start from there. In our study, we managed to get a significant number. At 18 is really quite a good number. We're not trying to generalize. We want to be able to get information that we can sort of bring to a particular area, which is in this Serious Illness Conversation Guide. We had majority female, a young group, and from a religious perspective, we did have members from a specific religious background, which was Hindu, but we didn't really see any religious themes that came out. And actually, the vast majority have been in Canada for quite some time, so greater than 10 years. So again, another weakness. You could argue, if this study was repeated with new arrivals, would this change? So what did we do? This is where Sakina and myself tried to relive the missed opportunity to be actors, and we played out the Serious Illness Conversation Guide. And you can see from the guide itself, it's got sections on it. It's really nicely laid out. And so we used those as ways of stopping when we were presenting. So what we did, I became a patient. Sakina was the clinician, the physician, and we went through the Serious Illness Conversation Guide and did that in front of our focus groups, and stopped at specific points asked them what they thought about those questions, asked them to think about if the question was posed to them directly or if it was posed to an elder within the community. And as we know, again, there is this difference between how conversations may come out with a younger group rather than an older group. And I think that's probably similar among all cultures, but particularly significant with Eastern cultures in terms of this filial piety and protection and so on. And anyway, moving forward from that, we were looking at a phenomena, which was the phenomena of someone having a serious illness conversation guide. So basically, it was a case of recording, transcribing, coding, reflecting on what it was. And the majority of our team members were from backgrounds from Eastern culture. So we had Filipino, South Asian, and Asian. So that was the strength that we could bring those lenses to the interpretation. So that was really quite important. Okay, next slide. So that's on to you, Lara. So this is about the key themes.
So like Amrish has shared, we did do the interview transcripts and identify the themes. We did just want to share that at the end of the presentation, we'll share a QR code in case you guys are interested in reading more about it, which is where we're pulling all these tables from. And what we'll do is we'll briefly touch on the three main themes that we really identified, and then obviously kind of share a quick overview of them in the next few slides. And then, Monica, Amrish, and Sakina might just jump in to kind of share anything if it has come up in our discussions. But really, this is just to lay the foundations for the next part where we have the recommended phrasing. And then obviously, we'll build us into the case studies that we'll have for the group discussions. So the first one that we really have was about generational differences. And we did find that there was quite a divide between the older generation and the younger generation. And there is a quote here that we think really just captures it. Our culture expects you to do everything with your family. This was pretty much kind of echoed by most of the participants that we had during our focus groups, both younger and older participants. And what they really kind of shared with us is that what looked like reluctance among older adults was often an expectation that their younger family members would do the decision making on their behalf if and when they end up losing that capacity. And then on the other hand, younger participants did understand the importance of advanced care planning informally or formally. And they really just wanted to have these conversations earlier since they are worried about this potential tension for when they find themselves in that position about making that responsibility for their parents or grandparents, but not necessarily knowing what their wishes might have been. So this was kind of like the first tension that we're noticing. Anything to add from Amrish?
I'll just jump in and just say again, it comes back to what I said earlier on, from my upbringing, speaking to an elder is you approach in a different way. And so what you're seeing here is one, I'm a South Asian who's grown up in the West. So you can see the younger generation more accepting of those ethical principles that we may use in a Western background in terms of autonomy, that I, if the patient, should know and I should be making the decision. Whereas maybe the older generation, it's really more the responsibility falls on the family unit and they make the decision. So you can see a bit of that conflict. And so again, and one thing I want to say throughout all of this is, as some of you may have come in and said, well, we want the words, we want the language. We're not going to give you that because clearly there's going to be various levels. And we don't want to say, well, you see someone who looks a particular way or speaks a certain way, this is the language you use. But this is just giving you ways of navigating any barriers you come across. So this is something to think about when you do see this, when you're having these conversations.
And I think Amrish touched on it, which is the second theme, which is the family structure really during these discussions. And I think we've touched on it there's a collective strength having this, large family members for some families, but also then having that hierarchy that might be embedded within some of those families. One of our participants really kind of phrased it nicely where there's a cultural veil around these deeply personal conversations where we might find that some of these complexities and nuances kind of gets a bit trickier to navigate with the more people in the room or having more of that hierarchy that they need to be aware of. So some of the key points from this specific one is that most of the participants shared that they almost felt like family involvement was essential. It wasn't a yes or no, but it's like it was a given that family will be involved in that whole process from decision making up till the very end. And alongside that, it's not an individual process, it's always a collective process. So there's something that we kind of refer to that's called relational autonomy, where, in the West, we're mostly familiar with the patient autonomy if they make the decisions for themselves based on their wishes. But this idea that relational autonomy then involves obviously the families or the members that they consider their own family. Hierarchy, as Amrish touched on, plays a major role. A lot of our younger participants felt that since they were younger, even though they might be more familiar, for example, in terms of medical literacy, that they found that their voices were not as loud or were not as kind of like listened to amidst the hierarchy of older family members or family members who might not necessarily know the patient best, but just because they were older, it usually deferred to them for decision making, which is compounded to with the collective strength. On the flip side, sometimes it makes it harder when there's a lot of family members who are then hoping to kind of like be involved in that decision making, which increases complexity in some cases and kind of detracts from the clarity of those discussions. Yeah, Amrish.
So Ken, I'll let you jump in.
Oh, I only wanted to add that in our Western medical ethics system, autonomy is kind of held like at the highest standard, and it really butts heads with Eastern values. And even when I was going through my training and doing palliative care, like I definitely felt like whenever I was with an Asian or South Asian family, like it was always a challenge to kind of, you know, dissect how important the autonomy of the patient was versus how much we have to value the collectivist values that go along with an Eastern heritage.
Yeah, and just to add to that, again, like you said, Sakina, we have these principles and they're not meant to be hierarchical, but the challenge in the West is autonomy is enshrined in legislation. It's a legal right. But what I also want to say is just make you think, all of us think, we talk about autonomy and everyone's heard that phrase, no person is their own island. In reality, whenever we're making a decision, it's never really autonomous. We're always thinking about people next to us, what they would want, what they don't want. And so relational autonomy, I mean, this was relational autonomy being exhibited by these conversations, right? That's what we're talking about. What is the link with their other family members when they're making the decision? It's never truly autonomous. No one really makes a decision without thinking about others. So this is sort of, I would say, just something to remind us all about.
And lastly, we do have the last theme in terms of power differential. And this was very evident in terms of like people like Amber shared, a lot of our participants were kind of like, have been in Canada longer. So they're more familiar with the kind of healthcare makeup that we have here, but they would always kind of refer to their loved ones or their older family members who kind of might defer to the healthcare providers more so than the younger participants. So we kind of named it as the power differential. And the quote that we have is they expect everything to come from the physician, which is kind of like, kind of leading back to what Sakina and Amrish said, kind of what we uphold in Western healthcare in terms of the patient should be making that decision for themselves. There's kind of a subverting of expectations with them expecting really for us to kind of tell them what to do. So the new main things here are really just from the younger generation versus the older or people who might be newer to Canada based on our participant group. So like we shared, they were often expecting us as the healthcare team to guide them in those decisions, to kind of tell them what their recommendations are, as opposed to the younger generations where they are more comfortable with having those discussions and making their own decisions. On the kind of like, I guess, the summary of it is that we always kind of assume that empowering them and letting them make that decision is something that we're doing for the patient. But some of the participants actually explicitly said that this would make my grandma or grandpa, for example, very uncomfortable because you are the healthcare provider. You're supposed to know, why are you asking me? So we just thought that that was a very interesting thing that came up during the focus groups. Amrish, Sakina?
Yeah, no, I again, this was just sort of highlighting what I'd already lived in terms of culture, not even necessarily from my work. And an interesting thing really is, particularly in this serious illness conversation guide or whenever we're having a conversation, do you have any more questions? And it was no surprise the elders in the family, out of respect, will probably say, no, I have no questions. Something just to think about again. Just because someone doesn't have questions, maybe actually they just don't want to ask you because they may insult you, or you feel you're being insulted by asking those questions. And as you said, Sakina, Lara, and Sakina earlier on, that really the expectation is, you tell us what you want us to do. That this understanding or this sharing of information and joint decision making is quite alien, and there's that trust. So again, being very careful with the words you use, because they will go wherever you take them, right? So, again, we touched on those main themes. And so what we have here, and we'll break it down, Sakina and myself will go through them, was just some of the suggestions that the participants came out with, and whether it was with consent and information preferences about illness understanding, sharing prognosis. And you can see these are specific stop points in the Citizens Conversation Guide for those of you who know it really well. And so we're just going to go through each of those and give you some of the feedback we got from the participants. But at the same time, this is, again, not supposed to be a cookbook, but really just something that you can refer back to if you're approaching that barrier. So we're not saying this is what you do, this is what you can do if you get to that point. So maybe, Sakina, do you want to start off with the first one?
Sure. So, asking permission seemed to be a very interesting thing in South Asian cultures. Um, you're the doctor. You don't have to ask permission. You are the authority. We are here to see you. Why are you asking for permission? It's kind of what came out of a lot of the elderly people who were part of this. The younger generation understood where this is coming from, but definitely it's like, no, no, I'm here to get information from you. I do not understand why you're asking permission from me. And I think that was kind of the main thing that came out of this. It's like, why would the doctor ask if it's okay to talk about my health? Well, that's why I'm here.
And one of the things is with the Citizens Conversation Guide, I think it's deliberately put in maybe as a warning to say that something's coming. And particularly within our group, they saw this warning, and it was a very quick way for the conversation probably to stop. Because then if it was focused at their elderly, they'd probably say to you, a doctor, could you stop? I think we need to have this conversation by ourselves. So it did what it achieved in just saying something's coming, but it landed in a specific way. And I think that was the other thing that came out. Illness understanding. So again, you're going to someone and say, well, what's your understanding of the illness? And a lot of our participants came back and said, what a crazy question. Like you're the clinician here. If you don't know it, why am I coming to see you? I know that sounds funny, but that was how that landed. So really, this idea of sort of asking how much you understood about your illness was confusing. The doctor is an expert. We're going to this expert to get this information, and what the doctor says is really, really important. So again, there was that part of it, and then the other part of the Serious Illness Conversation Guide is about sharing the prognosis. And this is where you're moving in about, that distinction between hope and worries. And again, a lot of our younger participants knew the reason behind this. Again, they understand this concept of autonomy, sharing information so we can help you make the decision making. But the older generations are probably looking and go, well, I don't know where you're going with this. Maybe this doesn't make sense to me. And again, it's a red flag for family members. So just something to be aware of. You're sitting in a room with the patient who's elderly and their family members. Again, this may be a sort of a red flag, and it might stop the conversation going any further because they can see that something's coming up. And that's the purpose of the guide. But at the same time, from a cultural perspective, maybe this is not going to work as well as it should do.
So, Amrish, when you say like when we're asking permission, sometimes it becomes a little bit challenging because you kind of you have even though we have asking permission, we do have a little bit of an agenda when we're having a conversation like this. So it's kind of how do you ask permission without, but actually it's like I'm not asking for permission. I want to have this conversation with you.
You're
So,
absolutely right. Yeah, and it's again part of that to bring it out to see how you pitch it, right?
so we had mixed reactions to like what are your goals? What are your fears and worries? What are your strengths? And so sometimes people took these questions a lot more concretely than um, they were probably intended. Like, my goal is to, keep working at my job, and it was a lot more less like they took it as, how their goals in terms of what they want for their life, their personal life, and not so much as what their medical goals were. And I think somebody, when we asked what are their fears and worries, I'm afraid of the dark. Like, like so sometimes these questions came across as a lot more concrete than really kind of framed around the medical expectations. And then even strengths, like, even though it says strength is a good word and well understood, it's like, I'm a good weightlifter, or I'm strong, so sometimes the way that these questions are asked do need to have a little bit of flavor added to them so that it's a little bit more specifically related to their medical issues. Um, yeah. And so these questions, when you do ask them, they do involve a little bit of vulnerability as well. So you have to have that rapport with your patient that you're dealing with so that they feel comfortable to answer these questions in the manner that they're intended.
Yeah, and it's interesting. I had quite a few quotes just come to mind. I mean, we lived through those, what is it, 18 hours of recording.
Yeah.
But what are your goals? Well, my goals are to make sure my son and my daughter are well educated and they get married. And you're going, oh, I wasn't expecting that to come out from the
Yeah.
serious conversation guide. Or, for instance, are you're worried? Do you want to have this treatment? You're going to get sick and so on and so forth. And so, a very powerful quote. I keep bringing it up. Doctor, the family was here before me, the family are here now, and the family will be here after me. So if it means the family wants me to go through this treatment to get sick, whether I have vomiting and so on, I will do that. That's my goal. And you go, no, but what is your goal? My goal is what my family wants. Okay. And so, again, the Seriousness Conversation Guide does bring up the values and goals, but it may be a bit different from what you might be expecting, might be the response.
Yeah.
So yeah, and maybe Monica, I don't know if you want to add anything to that because I'm sure this is not uncommon in terms of your discussions and experience with it.
Thank you. I think as you were speaking, I mean, I think it just really highlights the need for us to also be reflective when we are walking into a room, into, a conversation with somebody, is recognizing that the way we're phrasing a question may make perfect sense to us, but your example of, my goal is to have, my children go to university and get married. It is again about appreciating who is our audience to these questions, because today we're exploring the South Asian research, but at the end of the day, we are all here within healthcare, with whatever populations we are servicing and supporting. And we need to be able to recognize there's an individual with their own life experiences. And we want to try and present questions in a way that makes sense to them versus thinking, no, this is the tool that I have and this is the tool that I'm going to follow exactly, because perhaps that's easier for you in that moment. But the reality is we want to get as much input from our clients. And that does mean considering who our audience is. So thank you.
Maybe before we go to the case studies, I'm wondering, Monica, if you'd feel comfortable in sharing a bit more with some of the work that your team has done in terms of like maybe making those small modifications to the SICG for your lanyard cards, because I know that that was something that came out of it as well.
Thank you.
Sorry to
Yes.
put you on the spot.
No. That's okay. You know what? Honestly, Lara, one of the things as you were going through the slides, and I can't believe I didn't pick this up earlier in reviewing, is after, connecting with this research that you guys have done and bringing it forward to different units and programs, one of the things that really resonated with me was the idea of illness the term can be really perceived as negative and not necessarily a way to move forward and have a positive connotation. And so we did reach out to Ariadne Labs to say, look, I know you have this guide. One of the things our teams would like to do would be to adapt the language just on the term illness and shift it to health. And so I was pleasantly surprised just now as we're going through this to see that they actually have adapted that as well on their website. And I think it makes sense, as humans, we are always evolving, we're always learning, we're always trying to better engage with the people that we're supporting. And this one small shift, I think, means a lot to the people that are receiving the questions from this conversation guide.
So I just maybe just to sort of sign off from the research that we've done, and hopefully the exciting bit will be the cases. And really, I'm going to encourage you to jump in because all of you will have had experience and know really what we see as the barriers and how to navigate it. And we want to hear how you do it. But really, just to sum things up, really, again, advanced care planning serious illness conversation guides are experienced differently across cultures, which is what Monica's talking about. You need to really think about the audience that you're applying this tool, whatever tool that might be. Really, there is this emphasis in this tool on autonomy, and it is important. I'm not saying it's not, but also how do you navigate it and still sort of pull out that I want to say relational autonomy from the individual. And so particularly when it comes to South Asian community, and as I said, one of the commonalities that we found even when we're reading is sort of communities that are family centric. And what do I mean by that? Where really the family takes the responsibility of making the decision. As I said, they become the decision maker. As opposed to the individual, and the individual allows that, and that all comes from a place of love. That was another phrase that came out, that all of this wasn't about being obstructive, but it was about protecting our loved one. And when we talk about this hierarchy of sort of autonomy, non-maleficence, beneficence, and justice, most of these cultures, Eastern, particularly South Asian, compassion trumps autonomy. And that's what we're talking about, that they want to protect their loved one. And hence, this is where you see this filial piety, this filial paradox. Again, there was I can give you an example. A young individual was speaking to their granddad and saying, Granddad, you're going to be fine. You're going to live 100 more years. And Granddad saying, yes, I'm going to live another 100 years. But they both know something's up, but they're still protecting each other, right? This filial paradox. And so really, our role is to be able to act as that bridge, really facilitating these conversations. Again, Monica, you put it really beautifully in terms of how do we do that. And so we know the tool is good. It does sort of pull out those values and goals. But again, there needs to be this cultural nuance. And hopefully, some of this you'll be able to take away and adapt it to your situation or your sort of client or family members that you're talking to. That's how I sort of finish that part of it.
So I'm going to just kind of talk about this one person, and then I really am hoping that the audience will kind of weigh in because what I would do in a situation is going to be very different than what you would do. And I think this is a place where we can all really learn from each other what we can say or how we can approach the situation, and also just keeping in mind um, no culture is a monolith. Everybody is going to have, there are nuances, there are differences. We can't just kind of box people in based on the color of their skin or the way that they talk, or so we have to just kind of go with the flow when it comes to situations like this. So it's a 56-year-old woman. She was diagnosed with breast cancer. She was born and raised in Canada, but met her husband in India. He came here. They've been married for 30 years with 2 teenage children, and they live with extended family in the same house. She has some relatives, her mother, some siblings in India, and most of the conversations have been primarily with the patient directly. So I guess the first question really is what more do you want to know about this situation? And then maybe I can ask Amrish and Lara and Monica to kind of add in, like we were just talking before this session about, coming up on the cuff with different things like, the debaters and that kind of stuff. So maybe we can just come up with some more information as we're going through this case.
Tina, will you watch out for hands up or yeah, okay.
I don't know how hands up works on Zoom. I don't see any hands up.
I just saw a question from Kate in the chat, and she's actually saying, "What has she shared with her family?" Which I think is such a such an important question. And Maggie's adding in as well, what are the relationships of the patient with her husband and children? So maybe I'll throw it over to Sakina first about like, if and when this kind of situation happens and kind of touching on what has she shared and what's her relationship like, wondering how you've navigated that when it has
Uh,
come up.
Yeah, so I mean, maybe because she's born and raised in Canada, she has a good understanding of what the physicians are saying, but her husband, English is his second language, so she's just shared that she has this breast cancer and she's going to the oncologist to get some treatment. But her children obviously have lived here, and yeah, she hasn't really shared much with her kids at all because she's really trying to protect their teenagers because they're in high school and she doesn't want them to affect their studies or their social lives. And I'm going to say the relationship with her and her family and her like immediate family seems to be pretty good.
So again, I'm just wondering whether I answer it from sort of from those two questions. So
Yeah.
with Kate, what's shared with the family, like one of the things we might see is that she just shares with her because she's born in Canada. She would just be sharing it with maybe her husband. She may not share it with children. Whereas if it was maybe from the old country, everybody would know their business maybe. And then he said, what is the relationship of the patient with the husband and children? So again, from the old country, maybe the elders won't share that information with their kids, won't tell them, and maybe she's being more direct. So again, those are some of the things that and I think Maggie and Kate, you're right, need to take into account.
It's even hard to know, like, she may just be going to all of these appointments by herself and she may not be bringing anybody with her, or is she bringing people with her? It's a hard to know.
Can I throw out a question maybe to the audience out there? What potential barriers do you see? I mean, maybe from your own practice or from some of the things that we've shared with you today. Can someone throw out maybe some barriers that they may foresee?
Even just typing it into the chat box so we can all see it, because I know how uncomfortable it is, might be to talk.
If not, here we go. Concerns of being a burden. Yeah.
Mhm.
So yeah, for sure, with our own diagnosis, and again, I this is just me. Again, if it's an elder, I would imagine that the expectation would be, well, the family are going to do the best for me, and they will do what they need to. I see here concerns about advanced care planning and cultural beliefs they're talking about will bring it true. So yeah, absolutely right. So again, she was born in Canada. She may be comfortable having that conversation. This may be someone that in our group was very happy to talk about it. But and so that may not be so much of a barrier. Whereas if they were older, you're absolutely right. Talking about it may bring it on. That's something that we experience. I don't know. So Ken, if you want to add to that, or Monica or Laura.
One of the things
Oh,
that I've
sorry.
seen in situations like this is the family back home has a lot of opinions on what
Mhm.
should be and shouldn't be done, and weighing in with opinions that may actually cause more challenges than be helpful.
I also just wanted to add to Elizabeth, because I think you've touched on one that was quite prevalent in our discussions with the focus groups, is that talking about not even death and dying, but talking about illness was sometimes seen as a taboo. Or if you were to talk about advanced care planning with your elders, a lot of the younger participants shared that they almost felt like it was quite disrespectful to even bring it up, because sometimes the older family members might think it's, are you wishing bad luck on me? Why are you bringing this up? I'm still in good health. So we just really wanted to share that because it was kind of quite pervading through all our participants. And there's a couple ones that came up on the chat, so maybe I can read
I've
them out.
got one there. I'm looking at Navi. Navi's really gone deep here.
Hmm.
You can tell that this is obviously something that she sort of culturally is sort of attuned to, but she's talking about the responsibilities. So here we have someone who should be, I put in inverted commas, should be able to care for the family, look after the children. What does that mean? what are the pressures going to be coming from the old country, maybe back from South Asia itself. Something to think about. What's the expectations of the husband in terms of providing and for the family and so on. Maybe I'll get Sukaina to pick up a question, see if there's something that you want to respond to.
Oh, I could go on about, the relationship when it's a man who's sick versus a woman who's sick, and it has nothing to do with the South Asian background. But yeah, like there's definitely so many times where you see that it's the matriarch of the family that's responsible for everything, and when the matriarch gets sick, it becomes it unravels the social net that already exists.
Well, and I was going to say too, and in this situation with her, I think overall in healthcare being a relatively young person, having growing up here in Canada, but being a part of a marriage of somebody who did not grow up here, there also still could be that conflict within herself about navigating her husband's experience with healthcare and understanding of what this relationship may look like, and still being a bit torn about, physicians are kind of the gods. They are the ones to determine where this conversation goes. And so just how valuable and how important it is for us as a healthcare team to remember to open that door and say, like, would you like somebody else here with you? So that if she is comfortable having her spouse there or somebody else, then she knows like this is something the healthcare team is okay with.
Yeah. I mean, again, we could talk for a good hour on this particular case, but I think again, it's just bringing in, and I think the audience is also capturing some of the barriers that may potentially come up. Someone who's born here, maybe the husband who hasn't, and again, we're presuming, again, they've been here for 30 years, so hopefully they are able to understand the system here, but maybe the challenge would be coming from family members in the old country in terms of understanding what's happening. And then someone's put a comment there, but what about this getting the cancer, the taboo of cancer itself or having the disease itself? Why does that happen? Is it who's to blame, and what does that mean for treatment, and what the expectation is in terms of those conversations and treatment? I'm just wondering, sorry, go ahead, Sakina.
I mean, I think that I think it generates great discussion, and I don't think that there's ever going to be a right one answer, one approach. There's so many details that we did not add, and of course, you could have two identical people with, pretty much the same history, the same background, and react very differently. So it was really more to just foster that conversation and just realize that, there are definitely things that we have to take into consideration when we see a patient like this.
And Laura, I just saw your question there, before having the conversation, who would she want in the room? You're absolutely right. And she may be very comfortable having those conversations by herself, but then it brings in other dynamics as to family members who want to be in the room and want to find out what's going on. Maybe do you want to go into the next case? Because I know that's another good one. And I know that's we've got 13 minutes left.
Hey, so our next case that we wanted to bring forward and invite your input is an individual patient who is a widowed 85-year-old female who is at end-stage cancer, does have two sons and a daughter. She does live with her daughter, son-in-law, grandchildren, has not been able to move herself, is no longer independent, and appears to be in her final weeks of life. And so the need for discussion and for decision is around hospice care, or can this lady be supported in her current home setting? Conversations with the family members being present, having lived with her daughter has been there for these discussions and options. But she does have her eldest son who also lives nearby. Again, speaking to the idea of strong family connections, they are also having family members from outside of her city fly in to be present for this and to support the family. So again, kind of putting it out there to yourselves, recognizing some of the discussion we've had today. What do you think some of the conversation may include, or perhaps from your own experiences? What were some of the areas that you found a little bit different to navigate in these types of situations?
So Ken, I don't know if you want to answer Mira. Mira, thank you for sharing some personal history there. I don't know if you want to comment on that, Sukena.
Oh, I just like the comment. I just hearted it in the text message because I acknowledged that. Yeah.
Yeah, I think it comes down to, again, maybe with certain elders in the family, you might ask them, what did the doctor say? And they may come in and say, they said everything's fine. So that could be, maybe something was lost in translation, or they don't want to share it, or, that's the misunderstanding they had, or they don't want to involve or burden other family members. So there's a number of reasons that in my experience may come up from that cultural perspective.
And I think that people don't realize how perceptive, I mean, not, this is obviously not a young child, but how perceptive children are, in general. So when you don't share with them, they recognize something is wrong, but they're not being told. So
And it comes back to this filial paradox, right? The back and forth, to a certain extent, that I'm going to protect my loved ones and not share that information, or vice versa. So I'm just watching out for more comments. I think they've stopped for now. I was just going to throw in again. So, here's one new one coming up. What's that say? Similar gender expectations that may play out. Daughter as taking on primary caregiver role, caregiver fatigue, and navigating opinions, extended family, potential taboos of hospice versus hospice care versus providing care. So you're absolutely right. So again, within the family, what this means in terms of looking after mom, the expectation. There is, obviously, there's a son. Maybe the expectation is the son isn't going to be necessarily involved directly in looking after mom or moving in with mom. So you're absolutely right. That could play out. And then one other thing we maybe briefly touched on is like that, again, the hierarchy. We've got here the eldest son lives locally. So the daughter may be doing all the care and looking after, but maybe having very little say in what's happening, mom, and the son is coming in and as the eldest and making those decisions.
And
yeah,
I
the
think,
number of times I've come across a family where the daughter is doing all the work and the son is the one making all the decisions and the daughter's having to carry them out. Uh, yeah, it's not infrequent.
I was just going to share, and in my work in previous programs, I certainly come across exactly what was just being described, where the daughter is in fact supporting, mom at home with all of the medical needs and care that's required in a son who lives locally. And so what I did find with that paradox that Amrish was speaking of kind of not having one conversation with all members being present. But I think what is helpful sometimes is, again, when we have that family member, in this case, in my experience, was a daughter, being able to reach out and express and verbalize, some of the exhaustion and some of the anxiety she was feeling about this situation. And recognizing that, some options may not fit well for her, but allowing her to know that there are a variety of different supports that can be offered to hopefully try and meet her needs and within her comfort zone for her family.
So can I put you on the spot and ask you a question?
Sure.
Yeah. So in this case, you may have this elderly patient. She doesn't want to have the conversations, and the family want to sort of continue with that and make decisions on her behalf. How have you tended to navigate that?
The answer is with great difficulty. No, you know what? Honestly, I don't have a cookie cutter approach that I can kind of share. I probably would just start exploring. So, what are your concerns with having these conversations? How can I help you to facilitate making sure everybody can be on the same page as this? And you know what? Sometimes being a little bit more directive, being like, I know you don't want to have these conversations. Just none of this is going to change what's happening inside your body, but will give your family more peace of mind to help with the planning for the future. So being a little bit more directive like that.
And I know a number of times, we again, this filial paradox is playing out when you do have the conversation, the family trying to protect their elder, thinking they don't know anything, and then suddenly the elder says, well, yes, I know, I'm sick. I know I'm very, very sick. And then suddenly there's a gasp, and then everyone's like, oh, okay. So, I mean, that doesn't happen all the time, but again, most people when they're sick in the hospital, they know something's not right. And so sometimes helping them navigate that.
I do have to say that sometimes it is an asset to be the color that I am, because sometimes I think as I'm having some of these conversations, they're like, okay, she kind of gets where we're coming from because she probably has some shared experience here. So the fact that sometimes even that I introduce myself as a Muslim, sometimes when I'm with a Muslim family, it does help.
And I want to add to that. I think you're absolutely right. And also for those of us who aren't of color or from that same cultural group, just being able to be aware of it when you're having that conversation is really opens a door, because then that patient, the family understand, okay, you know something, you are trying to work with us, trying to navigate it. The other thing I would say, Sakina, on that same line, if you are from that particular culture group, it can also be a hindrance because the expectation is, you do not speak to our elders like that. You don't bring that up in the conversation. So that can flip on its side as well.
Oh, totally.
I was just going to share, I think what I really appreciated about with this research is that it is not prescriptive as to how we respond or perhaps how we shift the way we ask the questions from the serious illness conversation guide, because it does allow for that unique interaction that clinicians are having with their patients and or family members, whoever those support people are. And I think that was really refreshing. And I think empowering for our clinicians was, let's discuss these themes. Let's consider, reflect upon experiences you've had. How might you adjust the way this question is written to meet the needs of the person that you're trying to support so that you feel confident they've understood the question, and you've approached the correct people for that person's life. And I think that really allowed people to feel a bit more relaxed in that nobody is checking in that your phrasing is exactly as written, that you are in fact delivering that person-centered care, which I think was very helpful for the staff.
So I'm conscious, Lara, we've got 4 minutes left. I don't know if you want to put the last slide up. You've already shared the article for those of you who want to read. And then maybe, Tina, I don't know if there's any other questions as well that we need to sort of answer, or any other things that Sakina and Monica we need to touch on.
Maybe I'll just throw it over to you, Tina, because I know you have some closing remarks. So we've skipped and just put the link into the chat for anyone who's interested. And yeah, Tina.
Do you want to put the front cover up, Lara? I just want to say we were so privileged and so honored to have this work in the journal. And actually, we had no say in the actual artwork. And actually, if you can see it once Lara puts it up, they did really make an effort to sort of maybe add sort of a cultural sort of nuance to the actual article. You can see this family tree. You can see incense burning in the middle. There's some sort of maybe some traditional South Asian dress there, and then obviously this sort of traditional Arabic window or sort of like arch that you see there. So we're very, very honored that it was put in the BCMJ.
Well, wonderful. Thank you very much for this really insightful presentation. You know, as a non-clinician, it always reminds me of how fortunate we are to have fantastic healthcare providers like yourselves. You know, as complex as your jobs are in treating, the complexity of a disease or the illness, where I think you really excel is in the complexity of treating the person. And interacting and engaging with them, you know, having both that clinical knowledge, but also the knowledge of humans and humankind and how complicated and nuanced these conversations are. I really appreciate it. I'm sure that our participant learners today have as well. And thank you to the learners as well who were confident and comfortable enough to share some of your thoughts and suggestions. We will be sending out a survey as soon as you leave this presentation today. We encourage you to fill that out. It helps us understand what you valued in these sessions and also where we can go with future sessions. And a reminder to you as well that we have some really exciting sessions coming up later This year, our first 4 months of the year are actually planned. So we are running this month and next month, Flexing Your Core, our Foundations in Palliative Care, which is a course or a session every week. We have some grief and bereavement sessions that are always very popular coming up. And in early February, on the 10th, we have a session on supporting patients in long-term care who are LGBTQ+, that I think will be a really interesting conversation as well. So thank you again to everyone for attending. We will send out the recording and a summary of the conversation today within a week's time. And if you have any questions or comments, please reach out to the BC Centre for Palliative Care ECHO, and we can always get these to the presenters as well.
Thank you so much. Bye-bye.